Hello everyone, the topic of my discussion is hypermetropia. In this video, I will explain its causes, types, signs, symptoms, and treatment. Now let's start our topic. Hypermetropia is also called long-sightedness. Why it's called long-sightedness? Because a patient can see far objects clearly but have difficulty in seeing near objects. First of all, you need to know optics of a metropic eye. Person who has a normal eyesight, that is 6/6. Parallel rays of light coming from infinity, they are focused on the retina in emetropic patients. But in case of hypermetropia, parallel rays of light coming from infinity, they are focused behind the retina with accommodation being at rest. Here comes the diagram which shows rays are entering the cornea, pupil, lens, and image is focusing behind the retina. What are the causes of hypermetropia? Hypermetropia may occur due to shortening of eyeball. About 1 millimeter shortening of the anteroposterior dia of the eye results in 3 diopter of hypermetropia. It may occur when curvature of cornea, lens, or both is flatter than normal, resulting in decrease in refractive power of the eye. This one is the important point. About 1 millimeter increase in radius of curvature results in 6 diopter of hypermetropia. Index hypermetropia occurs due to change in refractive index of the lens in old age. It may also occur in diabetics under treatment. Now comes the positional hypermetropia, which results from posteriorly placed crystalline lens. Now the last cause is absence of crystalline lens, either congenital or acquired, following a surgical removal or posterior dislocation leads to aphakia, which is the condition of high hypermetropia. Now I will explain the types of hypermetropia. There are three types of hypermetropia: simple hypermetropia, pathological hypermetropia, and functional hypermetropia. Now I will discuss it in detail. Simple hypermetropia is the commonest form. It results from normal biological variations in the development of the eyeball. It includes axial and curvature hypermetropia. Simple hypermetropia may be hereditary. Now comes the pathological hypermetropia, results due to either congenital or acquired conditions of the eyeball, which are outside the normal biological variations of the development. It includes senile hypermetropia, which is also called acquired hypermetropia, occurs in old age due to two causes: curvature hypermetropia and index hypermetropia. Curvature hypermetropia due to decreased curvature of outer lens fibers developing later in life. Now comes the index hypermetropia due to acquired cortical sclerosis. In youth, the index of refraction of the cortex is considerably less than that of nucleus, and this inequality results in the formation of a combination of central lens surrounded by two converging menisci. This results in an increase in refracting power of the lens as a whole. In old age, refractive index of the cortex increases. As a result, the lens becomes more homogeneous and act as a single lens. Converging power of the lens as a whole decreases, resulting in index hypermetropia. Now comes the positional hypermetropia, which may occur due to posterior subluxation of the lens, aphakia, congenital or acquired absence of lens. What is consecutive hypermetropia? It occurs due to surgically overcorrected myopia or pseudophakia with undercorrection. Last type is functional hypermetropia, which results from paralysis of accommodation, as seen in patients with third nerve paralysis and internal ophthalmoplegia. Now I'm going to discuss components of hypermetropia. First is total hypermetropia. It is the total amount of refractive error which is estimated after complete cycloplegia with atropine. It consists of latent and manifest hypermetropia. Now, what is latent hypermetropia? As the name indicates, something which is hidden. It implies the amount of hypermetropia about 1 diopter, which is normally corrected by the inherent tone of ciliary muscle. The degree of latent hypermetropia is high in children and gradually decreases with age. The latent hypermetropia is disclosed when refraction is carried after abolishing the tone with atropine. Now comes the manifest hypermetropia. It is the remaining portion of total hypermetropia which is not corrected by the ciliary tone. It consists of two components, facultative and absolute hypermetropia. Facultative hypermetropia constitutes the that part which can be corrected by the patient's accommodative effort, and the absolute hypermetropia is the residual part of the manifest hypermetropia, which cannot be corrected by the patient's accommodative efforts. Briefly, total hypermetropia is the sum of latent plus manifest hypermetropia. In patients with hypermetropia, the symptoms vary depending upon the age of the patient and degree of refractive error. Patient may be symptomatic. A small amount of refractive error in young patients is usually corrected by mild accommodative effort without producing any symptom. At times, the hypermetropia is fully corrected, thus, vision is normal, but due to sustained accommodated efforts, the patient develops sthenopic symptoms. These include patient may comes to you with a complaint of tiredness of eyes, frontal headache, watering, mild photophobia, and these sthenopic symptoms worsen as the day progresses and are aggravated by prolonged use of near vision. Patient may come with defective vision with sthenopic symptoms or defective vision only or with the crossed eyes sensation. What is crossed eye sensation? Some patients may feel that their eyes are crossing without any diplopia. It also occurs due to excessive accommodation. What are the signs of hypermetropia? Size of the eyeball may be normal or may appear small as a whole, and cornea may be slightly smaller than the normal. Interior chamber is comparatively shallow and the angle is narrow. On fundus examination, optic discs appear small, which may look more vascular with ill-defined margins and even simulate papillitis, though there is no swelling of the disc, so it is called pseudopapillitis. Retina as a whole may shine due to greater brilliance of light reflections, short silk appearance, it's called. Okay, retinal vessels reflexes may be accentuated. The vessels may not uncommonly show undue tortuosity or abnormal branching. A scan ultrasonography, which is also called biometry, it may reveal a short anterior posterior length of the eyeball. Basic principle of treatment is to prescribe convex glasses so that the light rays they are brought to focus on the retina. And you should know the rules for prescribing glasses in hypermetropia. It includes total amount of hypermetropia should always be discovered by performing refraction under complete cycloplegia. If the total manifest refractive error is small, for example 1 diopter or less than 1 diopter, correction is given only if the patient is symptomatic. The spherical correction given should be comfortably acceptable to the patients. Children younger than 4 years who require hypermetropic correction can usually accept the full cycloplegic measurement. And once a child reaches school age, consider reducing the plus for the refractive prescription by about one third. But the child is not required to accommodate more than 2.5 diopter continually for the distance. The older children may not accept full cycloplegic refraction because of a blur at distance, so always first undercorrect and prescribe the glasses that the child accepts comfortably. Gradually increase the spherical correction at 6-month interval till the patient accepts manifest hypermetropia. And if there is associated exophoria, the hyperopia should be undercorrected by 1 to 2 diopter. But in the presence of accommodative convergent squint, full correction should be given at the first sitting. It may help in straightening the squint. And if there is associated amblyopia, full correction with occlusion therapy should be started. It is important to remember that hypermetropia may diminish with the growth of child, so refraction should be carried out every 6 months, and if necessary, correction should be reduced. Basically, glasses they are most comfortable, safe, and easy method of correcting hypermetropia as compared to contact lens and surgery. And in case of contact lenses which are that are indicated in unilateral hypermetropia, if there is an isometropia, for cosmetic reasons contact lenses should be prescribed once the prescription has stabilized, otherwise they may have to be changed many a time. And generally, refractive surgery for hypermetropia is not as effective or reliable as for myopia. That's all for today. I hope you all understand very well. Thank you so much.